Good afternoon. I'd like to thank the Philippine Heart Association for this opportunity to participate in this pre-convention activity. This is probably the last part of the presentations on the Philippine Practice Guideline for the management of hypertension. And so in this last session, we'll be having this particular activity on talking points on hypertension among persons with diabetes. And these are my disclosures of conflicts of interest. And this session will be a little bit different in that there will be this short lecture, and then it will be shortly followed by a 30-minute case-based discussion, and then the open forum. So let's begin. This will be the outline of the discussion in the next 15 minutes. We will talk about talking points on the epidemiology of hypertension in diabetes and the rationale for BP control in diabetes. Why do we need to control hypertension very well among persons with diabetes? Then we'll talk about the issues in the clinical management and the thresholds and targets for treatment. And then after that, we'll have the case discussion. And so the first talking point is that hypertension is quite common among persons with type 2 diabetes. It's actually an anticipated comorbid condition found in the greater majority of persons with diabetes. When we conducted the DiabCare Philippines survey way back in 2008, we found that hypertension is found in around 70% of these persons with diabetes, and these were already those with established diabetes, where the duration of diabetes was around 5 or more years. However, even among those who are supposed to be newly diagnosed, no, like in this survey in 2009, the CAN de Manila, we found that even among these groups, no, of people, 40% have hypertension. And so we found that even in the Philippine National Nutrition Survey, the one that I was able to conduct a study at is still the 2013 survey. And what we found is that when you compare people with diabetes and those who had normal glucose tolerance, this one, we found that in terms of course, their mean age, it was different. And of course, in terms of the prevalence of hypertension, it was likewise different. People who had diabetes had more than double the prevalence of hypertension compared to those who had normal glucose tolerance. And so that's the first talking point. It's quite common, and you anticipate it if you encounter someone with diabetes, especially established diabetes, type 2 diabetes. Always try to see whether they also have hypertension. Now, the second talking point is that for the greater majority of people also with diabetes and hypertension, we actually need combination medicines to achieve BP control. Most patients, with diabetes and hypertension end up with 2 or more combinations of medicines to control their blood pressure. And so we need to be adept at combining these drugs. We also need to be able to inform patients about this eventuality because many of them are quite surprised that they end up with even more medicines for the hypertension and the diabetes or the other problems. And so we have to emphasize to these individuals that BP control actually has a much greater impact on cardiovascular outcomes than even glycemic control. And so why do we have to be aggressive, or why do we need to pay attention to the control of hypertension? Because it's really quite difficult. But on the other hand, treatment of hypertension confers greater benefits in people with diabetes than in age-matched people with hypertension who do not have diabetes. Now, we always go back to this particular survey this particular study among newly diagnosed persons with diabetes, type 2 diabetes, the so-called UKPDS trial, where they actually tried to find out what was the impact of controlling blood sugar and controlling blood pressure on micro and macrovascular outcomes. So here we can see the outcomes or the study focusing on the blood pressure control. And so at baseline, these were the baseline of the people who were randomized to less tight and to tight control. And over the 9-year period, even those in the tight control were only able to achieve a mean blood pressure of 144 over 82 compared to those with the standard or less tight control. Now, the reason why I had included this study actually is to show everyone that in order for them to be able to achieve that BP control, and it wasn't even that ideal, as early as the third year, 60% no, of the people who were randomized to the tight control have actually ended up with two or more medications. And as time went by, the proportion didn't really increase that much. No, it remained more or less 60% needing two or more medications. But in order to maintain that blood pressure control, more and more patients needed more than two medications. So again, this is an important talking point. We have to tell people with diabetes and hypertension that as early, actually, as even for some of them, as early as the first year of diagnosis, they already had two drug therapy. It was needed to control the blood pressure. And as time went by, they will need more medications to stay within good blood pressure control. And so, really, the benefits, in fact, of the intensive blood pressure lowering may even exceed those of intensive glycemic control, especially for the prevention of cardiovascular complications. And we all know that it's important to do as much as we can to remove the risk factors for cardiovascular disease, as it is the most common cause of death among persons with diabetes. And so, therefore, again and again, we need to emphasize that blood pressure control is paramount and it's probably as important as treatment for dyslipidemia and treatment for the blood sugar control. And so we take a look at the outcomes of the UKPDS, again, taking a look at or comparing the outcomes if you tightly control the blood pressure versus a tight glycemic control, and taking a look at the benefits. So here you can see that for tight BP control, there was an impact on any diabetes related endpoint. Uh, Diabetes related death, around a 30% risk reduction. For stroke, no, 44% reduction. Heart failure, almost 60% reduction. And even for microvascular complications such as retinopathy progression and deterioration of vision and any microvascular endpoint, you can see the clear benefit of really controlling your blood pressure. Now, likewise, there is, of course, benefit to controlling your blood sugar. But here you can see that for microalbuminuria, the one in yellow, and microvascular complications, the one in green, no? Again, there is a lot of benefit, much like the blood pressure control and similar benefit. But when it comes to myocardial infarction, which is this one, the degree of benefit is actually a lot less. And here, it's you can see that the benefit was around only 16% relative risk reduction. So emphasizing that really the benefit of tight blood pressure control is more than that of just glycemic control in terms of these different micro and macrovascular outcomes, especially the macrovascular outcomes. And I took this slide from a slide set of Dr. Iris Isiptan, if only to emphasize to us that the benefit from glycemic control is actually quite modest in terms of the cardiovascular outcome as compared to the benefit from LDL reduction and the BP reduction. So a 4 millimeter drop in your BP prevents around 12 CV events. A 1 millimole drop in LDL prevents 8 CV events, while on the other hand, an almost 1% reduction of A1C over a 5-year period from baseline of 7.8% has a number needed to treat, which is 87. So a lot higher as compared to these. Now, at what blood pressure level do we start therapy? This is the third talking point. Majority of the guidelines that we reviewed while preparing to draft the Philippine practice guideline on hypertension did say that the threshold would be 140 over 90. So if you found someone who has diabetes and their BP is 140 over 90, taken twice, then that's the time that we can already start therapy. And typically, we mean by therapy here actually medications. Now, so here's the statement that summarizes what I said. No, among persons with diabetes, what is the threshold for treatment of elevated blood pressure? And here in the statement, we said that among persons with diabetes and hypertension, it's recommended that drug therapy, along with lifestyle change, be initiated at a blood pressure of 140 over 90 and above. And this is consistent with the section on the general guidelines for treatment, plus consistent also with the recommendation of many of the international guidelines on the management of hypertension. So the threshold is 140 over 90. The next talking point is I did say we start pharmacologic therapy. Is there a role still for non-pharmacologic approaches? And this is an important talking point. We generally de-emphasize this, no, because our drugs are so effective, but these are very important and similar to the advice for non-pharmacologic therapy among persons with diabetes. We should have sodium restriction, teach them what in the diet needs to be avoided in order to restrict sodium intake. We need to teach them about the dietary approaches to stop hypertension, this particular meal plan. And we need to emphasize exercise and physical activity, both the aerobic physical activity and dynamic resistance exercises. And again, abstinence from alcohol intake or moderate alcohol intake, weight loss, if possible, of around 5% or more from the baseline weight, and smoking cessation. Among persons with diabetes and hypertension, this is very important. We also need to screen for obstructive sleep apnea, as randomized controlled trials of people with diabetes have shown that treatment of OSA by CPAP actually also helps to reduce blood pressure or to control blood pressure. And so, if you take a look at each of the non pharmacologic approaches, it seems that the impact, no, on BP reduction is not that much. But taken together, they can have a significant impact in the way that we control the blood pressure, as you can see from this slide. Weight reduction around 5 to 20 millimeter mercury drop for every 10 kilograms weight loss. The DASH eating plan, which is a diet rich in fruits, vegetables, low fat dairy products, of course, within the context of their overall diet for diabetes, with a reduced content of saturated and trans fats, can lower down the BP to 8 to 14 millimeter mercury. Likewise, dietary sodium restriction by this much, physical activity of around 30 minutes of regular aerobic activity on most days of the week, almost 5 to 10 millimeter mercury, and moderate alcohol consumption, again, with this much BP reduction. So taken together, they will have a major impact. The next talking point would be, what are the BP targets for prevention of cardiovascular diseases? And so, in fact, in some of the guidelines, they would say that 140 over 90 is enough to be able to prevent or to reduce the risk for heart attacks, MI, or CV death. No? But in order also to benefit in preventing stroke and preventing the risk for nephropathy, and this is important because in the Philippines, the number one cause of end-stage renal disease leading to dialysis is diabetes, with hypertension, of course, being a major contributor. We have set a BP target of less than 130 over 80 in terms of the BP target among persons with diabetes. However, there's also some evidence of harm, especially for older people, and therefore do not lower down the BP below 120 over 70. So the international guidelines, the greater majority, 9 out of 12, actually say to set a BP target of less than 130 over 80 millipenter mercury because of the additional benefit to stroke reduction and nephropathy reduction. But individualize the target, especially for the elderly. The UK NICE has said that we target a blood pressure of less than 135 over 85 for adults, elderly adults aged less than 80, and for those who are older, even a much higher BP target of less than 145 over 85. Likewise, in America, the ACCHA said that in older people aged 65 years old, the target BP range systolic BP is around 130 to 139. The rationale for why we shouldn't push it down, on the other hand, to less than 120 over 70 is the Accord clinical trial, where in fact, when the BP dropped down to much lower than 120 over 70, there was also an increased risk of adverse cardiovascular outcomes. And thus, uh, while the threshold is 140 over 90 and the target is less than 130 over 80, the lowest probably is around 120 over 70 and not any lower. Okay. Now, the next talking point is what drugs are preferred for the treatment of hypertension among persons with diabetes. Guidelines recommend initiation of low-dose combinations of a RAS blocker, that's an ACE inhibitor or ARB, with a calcium channel blocker or a thiazide or thiazide-like diuretic, preferably using single pill combinations. Pre-tablet combinations may also be given if these single pill combinations are not available. On the other hand, you already know that combinations of ACE inhibitor or ARB are not recommended due to higher risk of hyperkalemia and heart failure. So the basis for this is there was a fairly large network meta-analysis done in 2016, which showed 2015, I'm sorry, which showed that there's no benefit of any single antihypertensive class in the reduction of mortality in hypertensive persons with type 2 diabetes. Reduction of CV mortality was only seen among those treated with an ACE inhibitor and CCB combination, which may be related to lower blood pressure levels. The basis for combining ARB and other drug classes would be the fact that ARBs are very similar to ACE inhibitors. They're both RAS blockers. And unfortunately, the combination of ARBs and other drug classes was not included in this network meta-analysis. Now, how about the combination of RAS blockers and thiazide combinations? The basis for that are the clinical trials, Advance and Accomplish, which showed benefit in these combinations. And so this is the last clinical question that we answered among persons with diabetes and hypertension. What are the preferred drugs? No? And so we did say that it should be a low dose combination of a RAS blocker with a CCB or a thiazide and a thiazide like diuretic, preferably using single drill combinations. As already stated in the general guidelines, the choice for starting on initial combination therapy results in greater achievement of BP lowering at the shortest amount of time. The low-dose combination therapy has been shown to be more effective than maximal dose monotherapy in the general population of persons with hypertension. So rather than starting low with a single pill and then going up and maximizing it out as monotherapy, our recommendation is a low-dose combination therapy to control the blood pressure of persons with diabetes. But again, do not combine an ACE and an ARB. So I think that was my last slide, my last talking point. And again, just to go back, the BP threshold for drug treatment is 140 over 90. The BP target to prevent cardiovascular outcomes, including stroke, as well as to prevent nephropathy, is less than 130 over 80 among persons with hypertension and diabetes. But not lower than 120 over 70, and individualizing, especially among the elderly who may be more at risk for orthostatic hypotension. So this ends the lecture. Please hold on as we will now proceed to the case discussion.